You are listening to the Nurse Documentation Podcast, brought to you by Nightingale.
Nurse documentation. Protect the care you gave. Protect the license you hold. With every note you save. Nightingale, where good care is safe.
Welcome back to the Deep Dive. Today we are getting into something that, honestly, it sits at the core of so much anxiety in healthcare. It's that intersection of patient care, the crushing time pressure we all feel, and what you could call legal survival. We're talking about documentation disasters. Now, if you work in healthcare, you've heard the mantra 1,000 times. If it wasn't charted, it wasn't done.
It's drilled into you from day one.
Right. But the thing is, that phrase, it's too simple. It doesn't even begin to capture the terrifying reality of what happens when things go wrong. The surprising truth, the high-stakes truth, is that nurses in facilities, they don't usually lose these massive malpractice cases because of a clinical failure in the moment.
No, not usually.
It's because of the chart. The chart fails them months or even years later. That paper trail, or really the lack of one, becomes this massive legal vulnerability. So our mission today, it's going to be a bit rigorous, maybe a little uncomfortable. We're going to unpack the specifics of 5 real, verifiable malpractice cases.
And these are sourced from deep data. We're talking about major insurers and risk management foundations like NSO and CRICO. These aren't made-up stories.
Exactly. Not hypotheticals to scare you. These are painful, expensive realities where, what seem like minor avoidable documentation mistakes just snowball into huge legal liabilities. And the cost, the numbers are just staggering. These 5 cases we're discussing today, just these 5, resulted in over $2.5 million in preventable settlements.
$2.5 million.
That money was paid out because the defense, they just couldn't prove that the standard of care was met. And it all came down to what was or wasn't in the written record.
I think it's absolutely vital that we frame this conversation the right way from the start.
Okay.
We're not looking at a chart through the eyes of a colleague on the next shift, just trying to figure out what happened.
Right, not for continuity of care.
No. We are looking at it through the cold, unforgiving eyes of a claims adjuster, a plaintiff's attorney, and at the end of the day, a jury. The second a patient is harmed, that chart stops being a communication tool. It transforms. It becomes an evidentiary document.
An evidentiary document.
Documentation is, quite simply, the ultimate professional defense. If your whole case relies on your memory of a chaotic 12-hour shift from 3 years ago,
you've already lost.
you've essentially already lost. The only thing that's trusted is the contemporaneous record, what was written at the time.
Okay, let's really unpack that shift in perspective, because that's the whole deep dive right there. Clinically, you're charting for your team. It's collaborative. But legally, it becomes colder, more unforgiving. So walk us through how that chart really operates as a retrospective record in a courtroom.
Well, the chart becomes the single source of truth that's used to reconstruct what happened. The legal team defending the nurse or the hospital, their entire job is to use that chart to prove the standard of care was met.
So they need to be able to point to a line and say, see, right here.
Precisely. They have to be able to point to a specific, timely, detailed entry and say, see, here is the proof that the nurse assessed the patient, saw the risk, and did the right thing. And here's the brutal legal principle. If that record is vague or incomplete, or worse, if it's contradictory, the case is often considered legally indefensible.
Wow. Regardless of how good the care actually was.
Regardless of the quality of the actual care. Your clinical intentions don't matter. The clarity and the completeness of the written record is the only evidence that stands. The second a lawyer shows a gap between what was required and what was written down, they've pretty much established negligence.
That just feels so profoundly unfair to the person at the bedside. They know they made the right call, they know they did the right thing, but because they didn't write it down in a specific way, it doesn't count. It's like leaving a crime scene investigation, but you forgot to log the key piece of evidence. You know who did it, but the jury just sees an empty evidence bag.
That is a perfect analogy, and it leads us straight to this dangerous myth that I think really poisons documentation culture.
Yes.
The idea that flow sheets are enough. Just checking the boxes.
Oh, yeah. We have to be realistic about the pressure. Nurses are relying on checking those boxes in the EMR for vitals, for assessments, for everything.
Of course. It's a reality of the job.
And I've heard so many nurses say, look, I checked the box for the Q4-hour vitals. Isn't that proof I did it? But you're saying that only proves completion of a task. It doesn't prove defensible clinical reasoning.
That's the nuance where the $2.5 million problem begins. A checkbox just says, I recorded this piece of data.
Right.
A defensible chart needs the narrative. It needs the story that connects that data point to your professional judgment and then to your action. You have to think of it in 3 parts: the finding, the rationale or concern, and the action.
Finding, rationale, action. Give me an example.
Okay, so a flow sheet shows a patient's blood pressure is dropping steadily over 4 hours. That's the finding. It's just raw data.
But if there's no note, no time-stamped entry that shows the rationale, something like recognized declining trend, concern for fluid loss.
I see.
And then the action. Notified Dr. Smith at 2 p.m., received order for a fluid bolus. Bolus started. Without that, in court, the chart makes it look like the nurse just collected data and watched the patient get worse.
So the absence of that little story, that narrative, it transforms what was probably good care into what the law sees as negligence.
Exactly. It's missing the professional context. That narrative is what turns a data point into proof of the standard of care. It proves you were thinking.
But let me play devil's advocate here. From the bedside nurse's point of view, they're already drowning. They have to be a therapist, an educator, a tech, and now an expert legal scribe. How is anyone supposed to find the time to write a novel every time they check a box, especially when they're short-staffed?
And that is the absolute key friction we have to address. Because you're right, the defense strategy can't be, I was too busy to chart. That just doesn't work.
So what's the answer? It's about efficiency and prioritizing what's defensible. We are not asking for a novel. We are asking for specific, focused notes on the critical events and the deviations. You have to chart the high-risk moment.
Okay, so not every single thing.
No. If the patient's vitals are stable, a quick note is fine. But when you see that heart rate of 136, or a family refuses a life-saving treatment, those are the moments you have to stop, take 90 seconds, and write the defendable narrative. Because those are the entries that will be put under a microscope in a lawsuit.
So you have to adopt the mindset that charting the abnormalities and the barriers, that's not extra work. It's non-negotiable self-defense.
Professional self-defense.
Exactly. Okay, with that legal foundation, let's dive into these 5 cases. We need to dissect not just what happened, but what was missed and, the direct financial cost of that mistake. Let's start in a setting where nurses are often working with a ton of independence, home health. This first case involves a 77-year-old home health patient. He's post-hip surgery, and he had a lot of other issues: Alzheimer's, incontinence, problems with walking. So he's already at a super high risk for skin breakdown.
And the insured home health nurse, she finds a pressure ulcer. It's on his left buttock, initially a stage 2.
So on the surface, this sounds like good nursing. She found the problem.
Right. And this story is heartbreaking because the nurse was trying, she was clinically engaged, she saw the issue, she educated the family on turning, she got orders for dressings. But over the next 2 weeks, that wound got much, much worse.
How much worse?
It progressed from a stage 2 to a deep stage 3. We're talking 1.5 by 1.0 centimeters with visible yellow slough. Then a second wound appeared, and ultimately the patient developed sepsis and died from complications related to these wounds.
Okay, let's pause right there. Let's get inside the nurse's head. What do you think she assumed was enough? What was her thinking?
She assumed her verbal advocacy was her proof. In her deposition, she testified that she repeatedly told her manager that this patient needed a specialist consultation. The wound wasn't healing, it was getting worse.
Okay.
She also remembered counseling the family multiple times that he really needed to be transferred to a skilled nursing facility for more intensive care, which the family kept declining. So in her mind, she's thinking, I tried, I told everyone, the decision makers either said no or the family refused.
But the chart, our star witness, it completely betrayed her. What specific documentation was missing that let the plaintiff's attorney just tear her defense apart?
There were 3 fatal gaps. First, her wound documentation was just too vague. She wrote that the wound worsened, but she didn't have the detailed objective measurements.
So no numbers.
No hard data. The regression from 1 centimeter to 1.5, the specific type and amount of drainage, the presence of that yellow slough. Without those precise details, the court assumes the nurse didn't really grasp how severe the decline was. Second, and this was the nail in the coffin for her defense, she failed to document her escalation, her request for a specialist consult. And third, she never documented her manager's specific denial of that request.
Wait a second. So the manager verbally told her no, and because she didn't write down that one conversation, the court put all the liability on her for failing to get the care.
Precisely. If she had documented it, and this is what we call the ideal chart entry, it would look something like this. Contacted case manager Gisto at 10:45 a.m. to request specialized wound care consultation due to progression to stage 3 and slow. CM denied authorization, stating it is unnecessary at this time.
Wow, that one sentence.
That one sentence shifts the liability. And then with the family, she didn't document the informed refusal. She needed to chart exactly what she recommended, why to prevent infection, sepsis, death, and that the family verbalized they understood those specific risks but still refused. Without that, the court just assumes that the family wasn't properly warned.
That is a staggering takeaway. The lesson here, especially for nurses working more autonomously, is you have to document the barriers.
Yes.
If a manager denies something or a family refuses, that paper trail of your advocacy has to be explicit. You have to document it to shift the responsibility. This case settled for over $220,000, basically because she couldn't prove she fought back against the resistance.
Okay, let's pivot to a completely different scenario, but one that's high risk everywhere: medication administration. This next case ended with a settlement of over $1 million for the nurse's portion. $1 million. This was a 19-year-old female patient with an incredibly complex and tragic history. She was ventilator dependent from a malignant neoplasm, had epilepsy and cardiac issues, specifically atrial flutter, which is key.
And she was ordered flecainide.
Yes, flecainide, which is a high-alert antiarrhythmic medication. The new order was for 25 milligrams twice a day through her G-tube.
Okay, 25 milligrams.
Now, based on the concentration they had on hand, which was 50 milligrams per 10 millilo, the correct dose of 25 milligrams would have been 1.3 milliliters.
1.3 milliliters.
But the nurse, who knew the patient well, administered 25 milliliters.
25. Oh my God, that's nearly 19 times the dose.
19 times the prescribed dosage. The patient died shortly after from cardiotoxicity. This is a devastating example of that deadly confusion between milligrams, mg/m, and milliliters, ml.
So what was the assumption here that led to the documentation failure? I'm guessing she just felt that checking the box on the MAR was enough, that the 5 rights were just, implicit.
Exactly that. The assumption was that by checking the box, she was implicitly affirming that she did all the verification steps. But when the plaintiff's lawyer asked for proof that she compared the order to the concentration on the vial, proof of her dose calculation, the chart was completely silent. There was no documentation showing she compared the order to the label. And critically, there was no documentation of the dose calculation or, for a high alert med, an independent double check. The absence of that paper trail was interpreted legally as a complete lack of due diligence, a disregard for safety protocols.
So this is a case of needing to show your work. Even if you think the math is simple, if you can't prove you did the process, you can't prove you were diligent.
Absolutely. A defensible chart for a drug like flecainide would need a narrative entry, something like flecainide 25 milligrams verified against order, concentration 50 millimilli 10 millivel, calculation confirmed, 25 milligram equals 5 milliliter, volume confirmed with second RN, John Smith, dose prepared and administered.
Hang on. In your example, 25 milligrams equals 5 millimol. But the order said 1.3 mLs. That's a huge discrepancy. That should have been a red flag right there, even before the overdose.
That's correct. The source material does note the order itself was complex. But even so, that huge variance between what was ordered and what a standard calculation would be, that should have stopped everything. And any clarification call to the pharmacy or the doctor must be charted.
So the lack of documentation suggested she didn't just get the math wrong.
It suggested she never even attempted the mandatory verification steps for a high alert drug. And that's what made the case impossible to defend and led to that massive settlement.
So the lesson is just brutally clear. Document your verification steps, especially for high alert meds. If you see any discrepancy, chart the clarification. And my God, train constantly on MEBIA versus ML. The chart has to show the brain work, not just the physical action.
Oh.
Okay, let's move to the chaos of the emergency department. This case involves an elderly patient who was already in the ED. She'd been evaluated for a fall and was just waiting to go back to her skilled nursing facility. While she's waiting, she has another unwitnessed fall, this time out of her chair.
Right. So the ED staff helps her back to bed. They do a quick assessment. And crucially, the patient says she has no pain. And since a head CT from the first fall was already clear, the team's focus was on throughput, getting her back to the SNF quickly.
They assumed she was fine.
They assumed they'd done enough, the patient was transferred. But as soon as she gets to the SNF, the staff there immediately sees she can't bear weight, can't walk. So they send her right back to the ED.
Yeah.
And this time, imaging shows a hip fracture, meaning the diagnosis was seriously delayed because of that transfer.
So the legal problem wasn't the fall itself, it was the follow-up.
Exactly. It was the lack of immediate defensible documentation. What was missing was the real-time assessment in the contemporaneous record. The note about the fall and what they did after was not written right away.
The source material says the nurse only wrote a late entry after the patient came back with the confirmed fracture. Why is a late entry so destructive in court?
It goes right back to what we said about contemporaneous proof. A jury sees a late entry as a cover-up. It looks like the team is trying to build a story to protect themselves after they know there was a bad outcome. It just destroys their credibility. The risk managers at CRICO explicitly said this one documentation failure moved their chance of winning from likely to unlikely.
So even if the note is completely truthful, the timing makes it look suspicious.
A jury just doesn't trust it. A contemporaneous note is evidence of what you were thinking and doing in the moment. A late entry is just a memory that you're using to build a defense.
Okay, so what specific details were missing from that late assessment that really mattered?
The specifics on her mobility. The nurse needed to chart objective findings. Patient denies pain isn't enough. The chart needed to show a real mobility assessment. And the key finding was that she was unable to bear weight.
So what would ideal real-time charting have looked like?
Something like, unwitnessed fall from chair at 14.10, assisted to bed, post-fall assessment initiated, attempted to assess mobility. Patient unable to bear weight on right leg, reports sharp pain on movement. Right hip appears slightly externally rotated, MD notified. Order for right hip x-ray received at 14.45.
And if that note had been there in real time?
The patient would have gotten the x-ray, the fracture would have been found, and the whole claim of delayed diagnosis just disappears.
The lesson is just brutal. Never rely on late entries for critical events. Document falls and post-fall assessments immediately and include specific objective mobility checks. If the patient can't stand up, you chart unable to bear weight. That's the data point that saves everyone. This next case is really upsetting. It involves a young patient, a 33-year-old woman, whose death from sepsis seems to have followed directly from ignoring a screamingly obvious vital sign. And this led to a settlement of over $1.1 million against the family nurse practitioner.
Yes, this patient comes to the FNP with what seem like localized problems. She has a history of chronic back pain, some skin lesions, and a low-grade fever of 99.8. But her heart rate was documented as a significant tachycardia of 136 beats per minute.
136, okay. That's a huge red flag.
A huge red flag. But the FNP diagnosed her with some bacterial and possible viral issues, prescribed some medications, but it did not order labs, did not order blood cultures, and did not send her to the ED. 2 days later, the patient came back in life-threatening septic shock from group A strep, and she died.
Heart rate of 136, with a fever and skin lesions. That's practically screaming early sepsis criteria.
It is. And the clinical failure was the FNP's decision to dismiss that vital sign. But what was her assumption? This is what came out in her deposition.
What did you say?
She testified that she assumed the 136 reading was just wrong. She said she believed the nursing staff often made errors with vital signs, or maybe it was just from the patient's pain or anxiety. She even said she remembered talking to the patient about the high heart rate.
Okay, but then we get to the documentation gap.
Exactly. The FNP documented the heart rate of 136, but then the chart was completely silent on any follow-up. There was no documentation of why the tachycardia wasn't investigated, no clinical reasoning.
No note of that conversation she remembered having.
No note of the conversation, and critically, no documentation of a differential diagnosis that even considered a systemic infection or sepsis.
So the chart itself basically handed the plaintiff's attorney the evidence they needed. The record shows a severe, uninvestigated abnormality, and 2 days later the patient dies from the very thing that sign was pointing to.
Precisely. The defense experts who initially supported the FNP really struggled. They admitted that given the patient's age and relative health, that unexplained, uninvestigated tachycardia was fatal to the case. A jury expects everything to be done for a 33-year-old. The defense was advised a verdict in their favor was remote, which is why the settlement was so large.
Let me challenge this a bit. So she thought the reading was wrong. How could she have documented that in a way that would have protected her?
She needed to document her rationale for dismissing it. If she thought the machine was wrong, she had to chart. HR rechecked manually at 15.30, rate 88, regular rhythm, original reading of 136 assumed artifact or error.
Oh, okay.
If she thought it was anxiety, she had to chart the intervention. Patient acknowledged high heart rate, states feeling anxious, provided education on deep breathing, planned to recheck in 30 minutes.
And if she didn't dismiss it?
then the ideal note would be abnormal vital sign noted, HR 136. Concern for systemic inflammatory response given lesions and fever. Recommended CBC, lactate, blood cultures. Instructed patient to go to ED immediately for any worsening symptoms. The bottom line is, documenting an abnormal vital sign without your clinical reasoning is incredibly dangerous. You have to chart why you ignored it or what you did about it.
Okay, our last case. This one really highlights how system failures, like floating staff and unclear assignments, can combine with documentation gaps to create the perfect storm. This is a 67-year-old patient, post-total knee replacement, with an epidural, who gets transferred to a med-surg unit.
And this patient was already a known risk. They had been hypertensive in the PCU. The defendant, RN in this case, was floated from critical care, so she's on an unfamiliar unit, and she has a really unclear division of labor with the LPN, who's also assigned to the patient.
A recipe for disaster.
It is. The patient declined fast. Nausea, vomiting, respiratory rate dropped to 10, O2 sats dropped to 91%. Then the patient became cyanotic and unresponsive. A code was called, but the patient suffered anoxic encephalopathy and died.
So what was the core documentation failure here? What was missing?
Non-compliance with the physician's orders. The orders were very specific because of the surgery and the epidural. They required vital signs every 30 minutes and specialized checks of the xiphoid process every 2 hours.
And what did the legal review find?
A complete lack of documentation for these ordered checks. Just big empty gaps in the chart where those entries should have been.
So they might have done them, but they couldn't prove it.
Exactly.
Yeah.
And the data that was in the system, like the blood pressure dropping over 2 hours, it didn't have any corresponding timely note showing the doctor was notified. Those critical vitals, like the RR of 10 and SpO2 of 91%, they weren't immediately followed by charting that showed the escalation.
And this case gets even messier because the people involved couldn't agree on what happened.
That was devastating. The RN and the LPN gave wildly conflicting stories about who found the patient and when the code was even started. A defense lawyer can't go to a jury with 2 different timelines. All credibility is lost. But the nail in the coffin was simply the lack of the ordered monitoring. If the order says vitals Q 30 minutes and the chart shows entries 3 hours apart, you can't prove the care was delivered. It's a non-negotiable proof point.
The assumption was probably that the LPN was doing the checks, and that just putting some vitals in the EMR was good enough. How could that RN have protected herself from this system failure and that $250,000 settlement?
By documenting clarity of assignment from the start of the shift, especially when you're floating, the RN has to chart something like assignment clarified with charge nurse at 07.15. RN responsible for meds and comprehensive assessments. LPN responsible for Q 30-minute vital signs. Will provide close RN oversight due to epidural.
So you create a record of the plan.
You create the record. So if the LPN fails, the RN's documentation proves she established the system of care. But beyond that, if the RN personally charts the ordered monitoring at the right intervals, she proves the vigilance was there. Ordered monitoring is non-negotiable. If the order exists, the entry has to exist at that frequency.
Okay, so we've just dissected $2.5 million in settlements. Now let's pull back and synthesize this. Let's look at the 5 common avoidable documentation patterns that just keep showing up in these cases.
Yeah.
These aren't just one-off mistakes. They're systemic weak points.
Yes, and these themes, they link all these tragedies together. They show us that the failure points are predictable.
Okay, theme 1, documenting abnormal vitals without clinical reasoning. We saw this in the sepsis case and the post-op case. This is basically charting data that incriminates you without charting the thought process that could save you.
Exactly. You're giving the prosecution the evidence of the patient's decline, the HR of 136, the dropping blood pressure, but you're providing zero proof that you recognized what it meant or that you did anything about it. Legally, that's interpreted as a failure to recognize a change in condition. The solution is to integrate that reasoning into the note. Finding plus concern plus action.
The challenge, again, is that when a machine beeps, the nurse runs in, fixes the problem, calls the doctor, and moves on to the next crisis. The charting is the last thing they think about, not an integrated part of the action itself.
And that's the cultural shift that has to happen. The charting is part of the action. And this is where the EMR should be helping, not hindering. It should force an entry for follow-up when an abnormal vital is entered.
All right, theme 2. Late entry documentation appears defensive. We saw this with the unwitnessed fall. This is all about timing and credibility.
Right. We established that any documentation you create after a bad outcome is discovered looks like a cover-up to a jury. It looks like you're trying to fill in the blanks to protect yourself. It just contaminates your credibility. The gold standard is real-time charting. And if a delay is truly unavoidable, say you were in the middle of CPR, you have to document the reason for the late entry to maintain that credibility.
Theme 3. Failure to document escalation attempts. This is the wound care case. The failure to prove you advocated for your patient, which you called documenting the barrier.
The court will assume you didn't advocate if there is no paper trail. Verbal conversations just vanish into thin air. The solution is to be rigorous. You chart what you asked for, who you contacted by name and title, when you contacted them, and their exact response, especially if it's a denial. You have to document the barrier to shift the liability.
Theme 4. Failure to document physician notification. It seems so basic, but we saw it in a couple of cases and it cost millions.
It's the failure to close the loop. If you call the doctor about a change in condition but you don't document it, the legal assumption is the call never happened. And the documentation can't be vague, not just MD notified. It has to be. Dr. Smith notified at 18.36 of patients RR of 8 and SpO2 of 88%. Orders received for Narcan. That detail is defensible and concrete.
And finally, Theme 5. Failure to document ordered monitoring. This was the post-op case. This is just straight-up non-compliance.
And it's the easiest case for a plaintiff's attorney to win. If the order says Q 30 minutes and the chart has a 3-hour gap, the defense is over before it starts. You cannot rely on your memory. If the order specifies a frequency for anything, vitals, neuro checks, whatever it is, you have to document it at that required frequency. It's mandatory proof of compliance.
So let's shift to the leadership view on this.
We have to. We need to move beyond blaming bad nurses or saying they were lazy about charting. These cases, all this money, they're symptoms of flawed systems, of documentation cultures that value speed and checking boxes over actual legal defensibility.
That's a really important point, because leaders, they often audit for completion rates. They run a report that says, did the nurse check 100% of the boxes? But you're saying that's not enough to lower the legal risk.
It's not just insufficient, it's dangerously misleading. Leaders are focused on the volume of documentation, not the quality or defensibility. If a leader sees a flow sheet with a critical vital sign like that heart rate of 136, but there's no corresponding narrative note showing follow-up, that leader needs to recognize that their facility is sitting on a time bomb of legal risk. The nurse checked the box but failed to prove clinical judgment.
So leaders need to stop auditing if the boxes are checked.
And start auditing if the documentation is defensible. Does it contain the rationale? Does it show the escalation? Does it close the loop?
So if I'm a CNO or a risk manager listening right now, what are the concrete preventative steps I should be taking tomorrow based on what we've discussed?
Okay, first, you have to audit for gaps. You need to specifically look for these 5 themes. Pull charts where there was an abnormal vital or a documented refusal or a fall, and then look to see if the corresponding clinical reasoning and action notes are actually there. Second, you need to implement strict policies around this. Create clear standards that require documentation of clinical reasoning and mandatory documentation of physician notification details, the time, the name, the specific orders. Make documenting the chain of command, especially denials, an explicit policy requirement.
And what about the EMR? How can you leverage that technology to force better habits and protect the team?
The technology has to be your ally here. Leaders should be using EMR features like hard stops for abnormal vitals. If a nurse enters a heart rate of 136, the system should pop up a mandatory field asking for the follow-up action. That forces the documentation at the point of care. EMR templates need to have specific, easy fields for charting, physician notification, and informed refusal, making it faster to do it right than to skip it.
So you're designing the system to make the defensible path the path of least resistance.
Precisely. We have to stop building systems that assume a nurse has time to write a long, detailed note on every single patient, and instead build systems that demand a focused, defensible note on every critical event and every deviation from the norm.
This deep dive has covered 5 really catastrophic cases, over $2.5 million in preventable settlements. And the root cause, again and again, was vague charting, damaging late entries, and just dangerous assumptions about what's obvious or standard practice when it's looked at through a legal lens.
Let this really sink in for a moment. Documentation is not just clerical work you tack on to the end of an exhausting shift. It is the ultimate form of professional self-defense, and it is patient advocacy. These cases are stark, expensive warnings. They show how critical it is to chart not just what you did, but why you do it, and maybe most importantly, what barriers you overcame. The manager who said no, the family who refused.
We really encourage you, the next time you're on a shift and you encounter that abnormal vital sign, or a manager denies a request, or you're forced to make a late entry, ask yourself honestly, If I were sitting in a deposition 3 years from now, would this entry be enough to prove my diligence and my professional judgment?
Share this discussion with your team, with your managers. You have to foster a documentation culture that's based on legal defensibility and clarity, with the understanding that when things go wrong, the chart is the only neutral witness in the room.
And here's the final provocative thought we want to leave you with. In a malpractice trial, it's inevitable. Staff members will remember things differently. They'll disagree on who said what and when. If your professional memory conflicts with a colleague's, and neither of your stories is backed up by specific, real-time documentation, who do you think a jury is ultimately going to believe? The chart or the damaging lack of one always wins.
You are listening to the Nurse Documentation Podcast, brought to you by Nightingale.
Nurse documentation. Protect the care you gave. Protect the